Hello everyone, this is Christina. In this week's threaded case study discussion, I have chosen to discuss endocarditis and septic shock as it pertains to our readings about various hemodynamic disorders. This particular case in review follows a 25-year-old IV drug user admitted with a history of fever, chills, and rigor. Upon admission, the patient appears flush with documented hypotension and had an elevated leukocyte count with polymorphonuclear leukocytosis. Later studies indicated a tricuspid valve murmur and positive blood culture. After being treated with antibiotics, the patient's condition worsened as he remained hypotensive, developing oliguria and a bleeding diatheses from venous puncture sites and other various mucosal surfaces. After further investigation into the potential pathogenesis of his disease process, there are several recent studies examining the relationship between infective endocarditis of the tricuspid valve and intravenous drug users. Damage from a variety of sources, including repeated injection of solid particles, disrupts the normally resistant valvular endothelium, thus increasing the potential for colonization. Despite the poor long-term prognosis and significant morbidity and mortality associated, there remain rather ill-defined guidelines for the medical and surgical management of these patients. Assessments indicate that infective endocarditis accounts for as much as 5 to 20% of admissions and 5 to 10% of all deaths. As a result, some of the more severe complications associated with such vegetation include embolic showering of the pulmonary vasculature, as well as other signs and symptoms indicative of congestive heart failure. On initial presentation, the patient exhibited fever and leukocytosis, indicating the beginning stages of the systemic inflammatory response syndrome. These sympathetic compensatory responses, in addition to tachycardia and tachypnea, are important indicators of the initial non-progressive stage of septic shock. This patient was later identified to have gram-negative bacteria in the blood, accompanied with hypotension and oliguria. These findings, combined with systemic vasodilation and hypotension, result from the progressive stage of shock, wherein tissue hypoperfusion and oxygenation become increasingly compromised. Later evidence of refractory hypotension, multisystem organ dysfunction, and coagulation abnormalities indicate a worsening in the severity of sepsis as the patient transitions into the irreversible stages of septic shock. Coagulation abnormalities result in endothelial dysfunction, microvascular thrombi, and impaired gas exchange, ultimately contributing to multisystem organ failure. Disseminated intravascular coagulation, also known as DIC, results in the release of tissue factor and other procoagulants into circulation, causing widespread injury to the epithelial cells. Such an acute bleeding diatheses is characterized by systemic activation of coagulation, leading to a consumption or depletion of factors required for hemostasis. Clinical presentation of DIC ranges from dyspnea, cyanosis, respiratory failure, convulsions, coma, and in this specific case, acute renal failure, circulatory shock, and death. Thank you for allowing me to share this case study with you, and I hope that you found this presentation on endocarditis and septic shock informative.